Good morning, viewers. Welcome to the second teleconferencing on the certificate program in healthcare waste management, and we will be covering course 2 of the curriculum. Course 2, as you know, contains about the topics on practical aspects, burn, non-burn technologies, and today we have invited two distinguished guests to this teleconferencing. On my immediate left is Dr. K.S. Bagotia. He is the State Program Officer for the Biomedical Waste Management in the National Capital Government of National Capital Region Government of Delhi, Directorate of Health Services. And on my extreme left is Dr. Sumati Muralidhar, who is the microbiologist in the Regional STD Center, Safdarjung Hospital. Welcome both of you to this teleconferencing session. And viewers, we will be covering quite a few topics in the 3 sessions. The first session will be from now up to 11:45. Then we'll have a 15 minutes break. During the break, we'll show you a film about the School of Health Sciences programs and focusing on the healthcare waste management program particularly. And in second session, we'll be showing you a film, a video film about the healthcare waste management prepared by the government of Delhi, and then we will have the third session. So the entire teleconferencing will go on up to 1:45 this afternoon. In the first session, first presentation will be by Dr. Sumati Muralidhar, who is going to talk to us about the integrated infection control management, including the disinfection and transportation. And she'll have about 20 minutes presentation. Then we will request Dr. K.S. Bagotia to make his presentation on the burn and non-burn technologies. So we will have this schedule up to 11:45. Now I'll request Dr. Sumati to give her presentation on the integrated infection control management, including disinfection and transportation. Dr. Sumati, please.
Thank you, sir. Good morning and welcome, viewers. Today I will be sharing with you some of the aspects of integrated infection control management, and which is a very, very important component of healthcare waste management. For this, we will first begin by knowing certain terms, like hospital-acquired infections. So what are hospital-acquired infections? They are also called as nosocomial infections or healthcare-associated infections. These are clinically recognizable microbiological diseases which can affect either the patient, the hospital staff, that is the healthcare workers, or visitors or attendants who are coming with the patients. These are infections which are acquired in the hospital, which were not present or incubating at the time of admission. Now, who are the people at risk? As I said just now, the patients, attendants and healthcare workers are prone for these kind of infections. What kind of patients? The immunocompromised patients, especially the ones with malignancy, diabetes mellitus, organ transplant patients, or patients who are on long-term antibiotics, steroids, or who are on catheters. Then we also have the post-operative patients, newborn babies, and the patient's attendants. And among the healthcare workers, there are certain disciplines where these infections are much more common, and this would be among surgeons, physicians, laboratory staff, the morticians, and of course the healthcare waste handlers. There are certain high-risk areas within the hospital for spreading these kind of infections. Although the entire hospital can be prone for these infections, we do have certain areas like the blood bank, the laboratories, operation theatres, intensive care units, infectious diseases wards, the burns wards, nurseries and labour rooms. For any disease process to occur, there are 3 factors which are interlinked, and these are called as the epidemiological triad. The factors are the agent factors, which include the microorganisms, the host factors, which include the human host, and environmental factors. So any disease process that occurs is as a result of a complex interaction between these 3 factors. Now, the kinds of infections that can occur in hospitals in the patients, that is the hospital-acquired infections, would be More commonly, they are the urinary tract infections, lower respiratory tract infections, wound infections or the surgical site infections, and bloodstream infections. These are the infections that are most common in the patients. While in the healthcare workers, the gastrointestinal tract infections, bloodborne and respiratory tract infections are more common. The agent factors which serve as predisposing factors for hospital-acquired infections include the virulence of the organism, that is the capacity to cause disease, and the antimicrobial resistant. Nowadays, there are a lot of organisms which come up with the multi-drug resistance, and this is proving to be a very big problem in tackling hospital-acquired infections. And the environment factors which also contribute to hospital-acquired infections include sanitation measures, the presence of antimicrobial resistant organisms, improper sterilization and disinfection measures, and of course improper waste management practices. Some of the common microorganisms which are involved in these infections include bacteria like Klebsiella, Pseudomonas, Staphylococcus aureus, Proteus, Acinetobacter, and there could be viruses, most commonly the HIV, hepatitis B virus and the hepatitis C viruses. Then you have the protozoa, and even fungi are capable of causing hospital-acquired infections. The important routes of infection are as follows: direct contact, especially with patients or with infected material. It could be the fecal-oral route, airborne transmission, or droplet infection as in coughing or sneezing, and by bloodborne route. Here again the HIV, hepatitis B and C viruses are spread in this manner. So as I mentioned, the complex link between the patient, the host, the agent, host and environment, the risk of transmission of bloodborne infections in healthcare setting can be, as a result, it can be a three-way process, that is from patient to patient, or from patient to the healthcare worker, or the healthcare worker transmitting infections onto the patient. So we have to take care of all these infections which can be transmitted in any of these forms. Just as an example here, the risk of transmission of bloodborne viruses to healthcare workers, the statistics show that for HIV virus, by percutaneous exposure, the risk is about 0.5%, while for hepatitis B, it can be as high as 40%, and for hepatitis C virus infections, the percutaneous exposure risk is about 3 to 10%. There are several health hazards due to healthcare waste. We must understand that there are two kinds of categories of healthcare waste. A small amount, that is 20 to 25%, is all that is infectious, whereas the bulk of the waste, which is 75 to 80%, happens to be the non-infectious waste. But if these two mix up, then we will end up having a huge quantity, that is 100% of infectious waste. This is not treatable by any particular technology, so it is ultimately sent to the dump sites, which can pollute the soil and even contaminate surface and groundwater. And the infections can also spread if waste is collected, stored, transported, treated or disposed of inappropriately. And if there is reuse of the disposable items like syringes, needles, catheters, IV and dialysis sets, these can also spread hospital-acquired infections. The indiscriminate dumping of healthcare waste without disinfection or with ineffective disinfection or sterilization can again result in epidemics of communicable diseases. And hospital waste can increase the population of pathogenic microorganisms in the general or the municipal waste. Here is a picture which depicts indiscriminate waste disposal, which is a definite hazard not only to humans but also to animals, as you can see. Now coming to the hazards to healthcare personnel or the healthcare workers, needle stick injuries are very important, and due to cuts, bruises from blades and other sharp instruments, they can occur in the healthcare establishments, and they can lead to severe infections. And infections can also be contracted by the healthcare personnel due to contact with patients, their blood, sputum and other body fluids. the healthcare workers can also end up with allergies to fumes and particulate matter, especially in the process of incineration. And hazards while administering radioactive and cytotoxic treatment can also cause disabilities among the healthcare workers. Now, apart from the dangers or hazards to healthcare personnel, there are environmental hazards also due to healthcare waste. And these include unscientific open burning of healthcare waste, especially those containing plastics, which can lead to air pollution by releasing the unburnt hydrocarbons and other toxic gases like dioxins and furans. And indiscriminate dumping of incinerator ash, which can contain toxic heavy metals, can also lead to soil pollution and groundwater contamination. So now, having known all these problems that can occur due to improper waste management, how do we tackle this problem? For this, it's very important that every hospital constitutes a hospital infection control committee and sets up a program to control these kind of infections. The chairperson of this committee is usually the head of the institution, and there are certain categories of staff members who are very important in this committee, and they include the microbiologist, the heads of all the clinical departments, and public health nurse. The functions of the committee would be to meet regularly and review the situation and do a surveillance of the hospital for healthcare associated infections and investigate any outbreaks as and when they occur and institute appropriate control measures. Now, apart from these programs which the hospital should constitute, the other important aspect is the standard precautions which have to be followed in tackling the hospital acquired infections. The standard precautions was earlier known by the term universal precautions, and they are sometimes referred to as biosafety precautions. The importance of these precautions, why we have to take these precautions, is because there are some diseases like the HIV/AIDS which have no cure or vaccine, and needle stick injuries, spills, and all these pose a very big problem, and in order to reduce all these infections, the standard precautions are very important. The definition is as follows. They are precautions consistently used for all patients regardless of their bloodborne infection status, because when most individuals are infected with certain organisms, they may appear asymptomatic. That means they do not have the symptoms, but still they would be having the infection. So it's always better to take precautions against any patients that we may be handling as healthcare workers. And how do we take these precautions? That is by proper sterilization and disinfection practices and safe disposal of biomedical waste. So the essence of standard precautions would be to break the link or the chain, the link between the source or the reservoir of infection and the susceptible host, that is the human host. So if you can manage to keep the agent, that is the microorganism, away from the host, then it's possible to prevent these infections from occurring. So that is the link we have to break, and how we do it is as follows. The standard precautions apply to blood, body fluids with visible blood, genital secretions, cerebrospinal fluid, the pleural fluid, pericardial fluid, peritoneal fluids, amniotic, synovial fluid, and even breast milk, because all these body fluids are capable of transmitting infections. And the benefits of standard precautions would be a reduced risk of infection both to patients and healthcare workers, and also the risk to the visitors and attendants, with the net result that there is a reduced transmission of hospital-acquired infections. Now, standard precautions, what does it involve? Hand washing, barrier precautions with the help of personal protective equipment, and collection of laboratory specimens appropriately, handling of spills, patient placement, transport, sterilization and disinfection procedures, appropriate waste management, and immunization of healthcare workers. So where are the areas where these are applicable? Although the entire hospital has to follow these precautions, that is, all the staff have to comply with these precautions, there are certain areas where extra care has to be taken. These include the operation theatres, wards, laboratories, sample collection centres, the blood banks, intensive care units, labour rooms and burns ICUs and wards. The basic requirements here would be personal protective equipment, we'll soon know what it is, hand washing materials, disinfectants, sterile equipment and a highly motivated staff. This is very important because it is only when the staff is trained appropriately and when they are highly motivated to perform the standard precautions, only then we will be capable of reducing these hospital-acquired infections. The safety measures for waste handlers would include, again, the hand washing, the barrier precautions like personal protective equipment, which involve gloves, aprons, masks, caps and boots, sharps handling and the ability to handle spills, transportation appropriately, and post-exposure prophylaxis and accident reporting. Any accident or mishap that occurs in course of their services have to be reported to the authorities or to the supervisors. A little bit in detail about hand washing because it is such an important exercise. It is a very ideal safety precaution which is very simple and cost effective, and washing with soap and water itself is enough very often to remove the skin microorganisms, and vigorous washing under running water for about at least 10 seconds is appropriate. The hands are often there are resident flora and transient flora on the hands, that is which resident flora are the bacteria which are always present and which are non-pathogenic. So it's impossible to completely remove the resident flora by hand washing techniques. But the transient flora, which are usually from the environment and capable of causing diseases, this is what we have to concentrate on removing during the process of hand washing. There are several ways of hand washing. There are types of hand washing which include the social hand wash, which is the ordinary hand wash carried out for about 10 seconds or so. Then you have the hygienic hand wash. This is in the course of patient care, which lasts about 30 seconds. And then you have the surgical hand wash, which is done for about 3 to 5 minutes very thoroughly just before operations. The hands must be washed immediately after contamination, before eating, drinking, leaving the workplace, after removal of gloves, at the completion of the day's work, and as and when it's deemed necessary. So there are certain points to note in hand washing, which include that the nails should be kept short, have running water available, use soap in some form. This may be in the form of a bar soap or a liquid soap or in powder forms, or even paper soaps are available, and clean towels must be used for drying. In instances where there is no available water, the hand rubs can also be used. These are alcoholic preparations where there is no need for water. They are just rubbed onto the hands and left to dry and evaporate on its own. Now coming to the personal protective equipment, the foremost among these are gloves. Whenever there is contact with blood or body fluids, one has to use gloves, and also for internal examinations, in operation theatres, for the collecting and transporting specimens in labour rooms, and for the purposes of waste management, heavy duty rubber gloves are appropriate. And biosafety regulations also dictate that gloves must be worn when handling infectious material or where there is a possibility of exposure to blood or other body fluids. One must never leave the workplace or walk around while wearing gloves. And one should use well-fitting gloves, which are either disposable or autoclavable gloves, and they should be changed whenever they are visibly contaminated or if there are tears in the gloves, and they should be removed before handling telephones. This is often a very common practice, that people feel very safe when they wear gloves, and they just go around touching all places here and there, surfaces and items. And the gloves must always be used in addition to hand washing and not instead of hand washing. So this is a very important point to note again. Waterproof gowns and special uniforms can be worn in high-risk areas like surgery and in the labour rooms. And if they are the reusable varieties, they have to be sterilized. Protective clothing also includes masks and protective eyewears. When splashing or spraying of blood and body fluids is expected, one has to use masks, and they can be washed if they are contaminated. The surgical masks are not enough to prevent airborne infections like that of Mycobacterium tuberculosis. So in these cases, special masks called as N95 respirators can be used. Even the HEPA respirators are sometimes used in certain conditions. And an occlusive bandage should be used wherever there are skin defects, and they must be covered with waterproof dressings. Here is a picture of two types of masks. One is the ordinary mask and the other is the respirators. And prevention of accidents, again, safe handling of sharps is very important in preventing accidents. And recapping of needles is a process which should never be resorted to. And puncture-proof containers are always required for the disposal of sharps. And one should always dispose of their own sharps and never pass it on to others. And during exposure-prone procedures, one must ensure that there is best possible visibility and protection from injury by using forceps instead of fingers. Spills have to be managed by covering the spill with blotting paper or absorbent cotton and 1% sodium hypochlorite, and then they have to be discarded in yellow bags and sent to the incinerator. So the take-home message here would be that the effectiveness of standard precautions depends on vigilant compliance by every healthcare worker, because often it's not possible to know when an individual is infectious. And as far as disinfection and transportation of healthcare waste is concerned, we all know that the bulk of healthcare waste is non-infectious, and it's only about 20% which is infectious. So we have to resort to appropriate procedures to get rid of these waste. And for this we have cleaning, disinfection and sterilization processes. The levels of disinfection would be low and high level. High level disinfection is almost like sterilization. Depending on for what purpose we need the item, we can resort to either disinfection or sterilization. And these could be by physical or chemical methods. Heat is the most important physical method. Dry or moist heat can be used. Like dry heat, we have the hot air ovens, the microwaves, and moist heat includes autoclaves. And among the chemical processes, alcohols and aldehydes are commonly used. So if it's non-infectious waste, there is no treatment required. But if it's infectious waste, depending on whether they are sharps or non-sharps, one has to appropriately use the disinfectant process. For storage and transport, waste cannot be stored for more than 48 hours, and there should be no spillage. They have to be covered and stored in inaccessible areas where rag pickers and sorters will not come, and they should be transported in covered trolleys, wheelbarrows or trucks. Here is a picture. One has to use the personal protective equipment like boots, masks and gloves whenever they are transporting waste, and the transport vehicle in a common facility will usually do it in a very organized way, where the wastes are all bundled in appropriate color-coded bags and transported for final disposal. Thank you.
Thank you. I think true to her profession, Dr. Sumati has given a very lucid presentation of the nosocomial infection and the points that she has made, that it is only less than 20% of the biomedical waste which is infectious, and the remaining 80% is general waste, and if we do not segregate, we always end up with the danger of mixing the infectious with the non-infectious, making the whole 100% potentially infectious waste. So I think the point she has made in the nosocomial infection control and how the healthcare waste management, if it is not done hygienically and according to the rules prescribed by the Gazette notification, then we are only going to increase the incidence of the biomedical waste management, you see, and that's I mean, we are only going to increase the incidence of the hospital acquired infection, and that is one of the main reason today that probably the hospital infection control committees that we are we propose to have, or we have them in the various large teaching and medium-sized hospitals, they are not that effectively functioning. And here I would like to ask a question from Dr. Sumati, that how is this that we have the hospital infection control committees, we also have the hospital infection control teams, but probably they are not working in the manner in which they should be working. So the how is it that what do you suggest that what is the role of the committee, what is the role of the team, and how they can be more vibrant? Because it has been seen that even in the teaching institutions there is this function is not very vibrantly carried out, and as a result we have more incidence and prevalence of the nosocomial infection related to the biomedical waste management. Just very briefly.
Yeah, actually the hospital infection control committee, first of all, every hospital must have an infection control committee, and it has to be a very dedicated team. So more often than not, what happens is, in addition to their routine duties, they are asked to do this as an additional thing. So sometimes what happens is, enough time is not able to be devoted to this.
Overburdened with the routine functioning,
plus,
and that's
the
where
role of training and motivation is very important.
Thank you, Dr. Sumati. And now we come to the second part in this session, and that is Dr. K.S. Bagotia's presentation. And let me tell you, friends, Dr. Sumati is of course one of our academic counselors in Safdarjung Hospital for this the certificate program in healthcare waste management, and Dr. Bagotia has done a tremendous job. He has been very helpful by nominating number of, I think, about 8 to 10 learners in this program in Delhi, and we are grateful to you, Dr. Bagotia, for this, and we look forward that you sponsor more and more candidates to these programs. It is not from our point of view only, but also to help develop the capacity or the capacity building of the personnel in the hospitals and in the healthcare sector and such. So Dr. Bagotia, could you please give your presentation, please?
Good morning, listeners. I'll be talking on the burn and non-burn technology for healthcare or the biomedical waste. What is waste? Anything which is not intended for further use, we may term it as waste. And what is biomedical waste? That means the waste generated during the healthcare. It may be diagnosis, treatment, immunization of human beings, animals, or in research activities pertaining thereto, or in the production and testing of biologicals, including categories mentioned in Schedule 1. What are the objectives of waste management? The first objective is reduce infection or hazards or hazardous nature of the waste. Second is reduce volume of the waste. Then prevent misuse or abuse of the waste. The fourth is aesthetics consideration, and fifth objective is ensure occupational safety and health. What are the options available for waste management system? This may be the option available for final disposal, the training requirement for operation of the method, operation and maintenance considerations, then available space. If space is less, I cannot install the facility. Location and surrounding of treatment site, then investment and operating cost, what kind of technology I need, seeing my economy, then health and environment considerations, public acceptability, and regulatory requirements of the country. Ideally, we should do green procurement. That means while we are procuring things, we should substitute heavy metal thermometers with electronic ones, substitute PVC with polypropylene and polyethylene, reusable and recyclable things should be used, products without coloring agent or the heavy metal should be used, then environment responsible vehicles should be there, use energy saving devices, and then purchase durable equipments. How can we reduce waste? Use two sides of photocopying, for example. Use electronic mail that will not require most of the paper. Buy in bulk like food, drinks, detergents. Reroute publications, magazines if you have used, then to friends in library. Single space text that can be used. Energy efficient appliances, then use computer fax software, and segregate biomedical waste. How can we recycle? That means newspaper, telephone books, recycle used towels and rags for other purpose, use plain paper fax machines because they are durable, recycle following items, like saline bottles, glass bottles from juice and baby formula, juice and food material containers, newspaper, plastic containers, locate market for recyclable waste, and install silver recovery unit. Because if we are recycling it, we will produce less of the waste. We can reuse also, like donate used publication to doctor office, library, reuse worn clothes, diapers and towels as rags, reuse scrap papers for notepad and draft copies, reuse reusable urine trays, then use reusable drapes and gowns, and use old envelopes by applying label on it. Why should I manage the waste? Because it may cause lot of hazards. And what are those hazards? First is the infection. The commonest infections are gastroenteric, then respiratory, ocular infections, genital infections, skin infections, meningitis, HIV/AIDS, then hemorrhagic fevers, septicemia and bacteremia. Other hazards may be genotoxicity and cytotoxicity, the chemical toxicity of the waste, then radioactive hazards if you are using radioactive material during treatment, physical injuries due to sharps, and public sensitivity, like if you are throwing placenta or the body parts into the municipal dustbin, then there will be hue and cry from the public. What are the components of waste management system? We should see at the point of generation, segregation of waste, then decontamination. This can be done by thermal, it may be dry or wet thermal, then chemicals, physical methods we can use radiation, microwave, ultraviolet, deforming and destruction by shredders and needle destroyers, and temporary storage. What are the technology requirements? Say first is well organized collection and transportation system. For dry heat we can use incinerator with wet and dry scrubbers. For wet heat we are using autoclave, microwave, hydroclave and any other non-burn technology. Shredders and needles, then effluent treatment plant, automation of feeding equipment is must, and backup of power failure because lot of power breakdown, and other factors we should keep in mind: ergonomics, aesthetics, and proper recording and reporting. The various treatment modalities are mentioned under the biomedical waste management and handling rules, but the category 1, 2 and 5, that means they can be incinerated, and rest other categories can be used to non-burn technologies. Open burning is very common, and that's very controversial because open burning releases harmful obnoxious substances like oxides of sulfur, oxides of nitrogen, carbon dioxide and suspended particulate matter. Certain organic gases are carcinogenic like dioxins and furans, and open burning should be strictly avoided. You can see the open burning, some of the photographs. What are the principles of incineration? Because incineration is a high temperature dry oxidation process that reduces organic and combustible waste into inorganic and incombustible matter and results in very significant reduction of waste volume and weight. The combustion of organic compound produces mainly gaseous emissions including steam, carbon dioxide, nitrogen oxide and certain toxic substances, and particulate matter plus solid residue in the form of acids. What is the waste suitable for incineration? We can see the low heating value above 2000 kilocalorie for single chamber and 3500 kilocalorie for pyrolytic double chamber incinerators. The content of combustible matter should be above 60%. The content of non-combustible solid should be below 5%. The content of non-combustible fine should be below 20% and moisture content should be below 30%. What are the waste types that should not be incinerated? One is the pressurized containers, large amount of reactive chemical waste, silver salt and photographic and radiographic waste, then halogenated plastics such as polyvinyl chloride, PVC, Waste with high mercury and cadmium contents such as broken thermometers, used batteries, lead lines, wooden panels. Then sealed ampoules or ampoules containing heavy metals. What are the types of incinerators? There are three basic types of incineration technology used in healthcare waste. First is double chamber pyrolytic incinerator. Second is single chamber furnace with static grate. Use of this kind of incinerator is discouraged due to environmental problems. And third is rotary kiln operating at high temperature, capable of causing decomposition of genotoxic substances and heat resistant chemicals. If you are talking of the double chamber incinerator, we can see what is the capacity, make and type of the incinerator. The temperature in the primary chamber should be 800 plus minus 50 degrees Celsius. In secondary chamber it should be 1050 plus minus 50 degrees Celsius. Whether we are chlorinating the plastic, whether chlorinated plastic material we are incinerating, we should keep in mind we should not. The fuel used, it may be sulfur or diesel. Then stake height of the incinerator should be more than 30 meters. We should use scrubber or the pollution control device. Acid disposal should be kept in mind, and aesthetics of treatment facility should always be kept. You can see the open burning, they can call it steel incinerator. The Harris neck incinerator in some of the countries. In Malawi Incinerator you can see before and after the regulations. Then at some places like in Tibet they are using the photor, that means through ultraviolet rays. You can see the incinerator used in Bangladesh, the incinerator used in Indonesia, heart incinerator, this technology is sometimes used in India also, incinerator in UK, incinerator with cyclone separators, that means pollution control device. This is the advanced incinerator with double chamber, all pollution control device, automatic feeding. And there is community waste energy incinerator where they are recovering energy from the incinerator. There is plasma pyrolysis. They are using plasma torch for burning the waste. You can see the plasma torch. And plasma pyrolysis projects used in Dharamshala in India. What is plasma pyrolysis and what are its advantages? This process reduces material to more basic chemical components by intensive hot gas plasma in absence of oxygen. Plasma torch can be created by striking a discharge between two electrodes at temperature more than 10,000 degrees Celsius. The plasma pyrolysis fragments organic and inorganic molecules found in the waste. It reduces volume, say 1/200th of the original size. For example, I am using 1 ton of the waste, the residue will remain 5 kg only. It can handle any material in any form without loss of destruction efficiency. What are the disadvantages of plasma pyrolysis? Plasma are normally generated by high energy electrical discharge and require considerable amount of energy to operate, thus increasing the cost, and therefore cheaper non-burn technology are used. While plasma differs from incineration, plasma pyrolysis system claims environmental standards are maintained. They say that no air, soil or water contamination, but no full-scale plasma pyrolysis system are available for the waste. And some of the data shows that still dioxins and furans are formed in the plasma pyrolysis also. This you can see the loader, automatic waste feeding. Ecolates, they are also using programmable logical control. They can even mount it from the distance place. This is the flue gas incinerator. This is the scrubber system in the thermal oxidizer. That means the flue gases, they are cleaned. For heavy chemicals and cytotoxic drugs, they are using rotary kiln. Another type of rotary kiln you can see at the larger scale. If I talk of Delhi's, what is the incineration capacity in Delhi? You can see around 2675 kg of incineration capacity is available per hour. And what are the hazards of incineration? The studies have shown that the childhood cancers due to incinerators are very common. Within 15 kilometers periphery you can see the most common childhood cancers. If there is accident at the incineration site, there can be fire. The best use of incineration technology is if we are using centralized facilities. In Delhi also we are having two facilities, one under the government collaboration, another in the private sectors. Government is also planning another facility at Gazipur. The government has fixed some of the rates for centralized facility, that is rupees 72 per bed per month on 8th bed onward, and 540 rupees for the units which are having up to 7 beds. The centralized facility with the name BioCare Technological Services in SME industrial area, they are using incinerator, autoclave, shredder with ETP. The second facility is handled by Synergy Waste Management Private Limited. They are also having incinerator, autoclave, shredder with ETP, and they are serving almost 1800 units. You can see the photograph of centralized facility. The incinerator centralized facility, they are having double chamber with PLC system, with computer monitoring, with ETP. This is the autoclave system. Two kind of autoclaves are used in the non-burn technology, that is gravity flow autoclave and vacuum autoclave. The vacuum autoclave is considered to be better, but there is need of sterilization monitoring and validation test. You can see the photograph of the autoclave and shredder. The shredder appears to be good, but this doesn't have the automatic feeding system. The another autoclave for sterilization. The technology autoclave with the modified names, hydroclave you can see, the few photographs you can see. Then microwave, the another technology, non-burn technology, we are using microwaves, and advantages are that no decomposition of material or so-called liquid and gaseous emissions, efficacy test or routine test is required, and automated and easy to use. The disadvantage is it is costly and some offensive odor may be there. Some of the photographs you can see of the microwave. We are also using chemicals, and most effective chemical used in the hospital is glutaraldehyde. That is very effective against bacteria, fungi, viruses and spores. We require mutilation. It may be shredder or it may be needle destroyer. You can see the photograph of needle destroyer, and sharp container also to prevent injuries. We require ATP wherever we are releasing liquid waste, and there are some standards given for that. You can see the equipment installed for ATP. We require to keep in mind occupational safety and health by using gloves, face masks, gowns, special care to prevent sharp injuries, avoid aerosols, hand washing. The other technology other than the incinerator available in the market, I can name some of them: the autoclave, hydroclave, thermoclave, logmat technology, STI chemclave, then alkaline hydrolysis, MMT 300, AWS clinical waste, microwave. And you can see some of the photographs: logmat, thermoclave, hydroclave, STI chemclave, then waste reduction technology through hydrolysis. You will find at the PS14, if you treat them at 150 degrees Celsius, all organic material will be dissolved and only bones will be left. They are shredded. Thank you very much.
Thank you very much, Dr. Bagotia, and we come to the end of the first session. In the break we will not be able to show you any film, but after the break we will show you very interesting film, and Dr. Ruchika Kuba is with me and she will take over for the presentation and discussion on the film in the second session. We'll be back after 15 minutes. Thank you very much.